The present topic of discussion, it is on blood disorders, and this is a part 2 of blood disorders wherein we will be discussing about disorders of platelets, that is bleeding disorders will be seen. The most important of these bleeding disorders we shall discuss in this topic. So it is bleeding disorders or disorders of platelets. So we shall discuss a little basic about platelets first, then followed by the disorders. So platelets, basically they are also called as megakaryocytes. So these are the smallest of those blood cells which are non-nucleated structure. That means these are the cells which doesn't contain nucleus like that of RBCs, and they contain some granules which are red to purple in color, and these granules are the ones which contain factors that helps in activation of platelets and help platelets in clotting mechanism. Like I told you, platelets, they help in clotting. So whenever there is any injury, so blood has to clot to restrict the bleeding. So that process is called as hemostasis. That occurs in two steps, that is primary hemostasis and secondary hemostasis. So how does platelet help in primary and secondary hemostasis is that under primary hemostasis, first all the platelets, they come and aggregate at the site of the injury, restricting the blood from oozing out, and then followed by secondary hemostasis, wherein the clotting factors which are present in the plasma, they get activated, resulting in the fibrin formation, and this fibrin, it will come and aggregate, wound around these platelets, resulting in a clot. So this is a diagram which shows a brief mechanism of clotting. Okay, so think that this is the circle which is rounded there, that is the site of injury, wherein as there is a site of injury, the platelets will become activated, and at the same time the clotting factors within the plasma are also activated. Before that, the activated platelets, they come together, they aggregate, and they close the area of the injury. So this is a temporary action. Okay, so this is the primary hemostasis, followed by, as I already told you, the clotting factors get activated, right? So either it will be intrinsic or extrinsic pathway, wherein prothrombin will activate thrombin, and thrombin will convert the soluble fibrinogen to insoluble fibrin. So this fibrin formation is important. Why? Because it helps in secondary hemostasis, that is, this fibrin strands, they will adhere to the already aggregated platelets, helping in the clotting. Okay, so this is about a clotting mechanism in brief. And as I was telling, clotting factors within the plasma, right, there are 13 different types of clotting factors we have. Okay, so this is the normalcy. So if at all any disorder has to occur, either it has to be within the platelets, that is number of platelets or function of the platelets, or it has to be within the clotting factors. So the bleeding disorders will revolve around disorders of clotting factors or disorders of platelets or function of the platelets. So now let's see the disorders. The first of it, what we are going to discuss here is thrombocytopenia. Penia anywhere is, it tells that decrease in the number. So here thrombocytopenia. So here there will be decrease in the number of circulating platelets here, which is below the lower limit of normal. So what is the normal count of platelets? It is 1,50,000 to 4 lakhs per microliter. So if it is the lower limit is 1,50,000, so anywhere below 1,50,000 per microliter, it is thrombocytopenia. So what causes this thrombocytopenia? So there are 4 important causes that results in decreased platelets count. So first one is impaired platelet production itself. The production of platelets itself will become impaired. So what are all the situations wherein the platelet production is decreased? It is either generalized bone marrow failure, in case of any aplastic anemia, or marrow infiltration by any cancers, wherein along with platelets other cells also get decreased. Or it can be by selective suppression of platelet production itself. Only platelets get decreased by some drugs like thiazides or cytotoxic drugs. So this is about impaired platelet production. The next cause is accelerated platelet destruction. So here platelet production is normal, but the destruction is very much faster. So this can be either immunologic destruction by any autoimmune disease, or it can be non-immunological destruction by disseminated intravascular coagulation or thrombotic thrombocytopenic purpura. So by like this, platelets can be destructed faster, or it can be by splenic sequestration. That means within the spleen there can be destruction of the platelets resulting in decreased number. So that can be seen in splenomegaly or hypersplenism. And the next cause of thrombocytopenia is dilutional loss. So this dilutional loss, it is seen in massive transfusion. So whenever there is any massive blood loss, there will be multiple transfusions to that person. If a massive transfusion of old stored blood, so wherein there will not be any platelets, then thrombocytopenia can occur. And this thrombocytopenia, it is of mainly two types: immune thrombocytopenic purpura, which is also called as ITP, and the second type is thrombotic thrombocytopenic purpura, TTP. So now let's see about immune thrombocytopenic purpura, which is also called as idiopathic thrombocytopenic purpura. So both ways we can call it as ITP. Here idiopathic or immune we are saying. So there will be immunologic destruction of the platelets here. So how does this immunologic destruction occurs? So first of all, before discussing the pathogenesis, on the basis of duration of this illness, this ITP is classified into two forms, that is acute ITP and chronic ITP, and both of them will have different pathogenesis, that is both of them will have this different immunological destruction of platelets. So what happens in acute ITP is that usually this is a self-limited disorder which is seen in children, and in children also who are recovering from a viral illness. So like cytomegalovirus infection or infectious mononucleosis or hepatitis C, such virus infections. So any viral infection, there will be antibodies within the body that are produced against the viruses, right? So these antibodies which are formed against the virus, what they will do is, like in this particular disease, they cross react with the platelets of the host itself. So whenever they cross react with platelets, they cause immunologic destruction. So this cross reaction can be maybe by molecular mimicry or any other reason. But here the antibodies which are formed against these viruses, they cross react with platelets. Next, chronic ITP, it is actually autoimmune disease. So autoimmune disease in the sense autoantibodies will be produced within the body. So here the autoantibodies will be against the platelets itself. So on the platelets there are too many glycoproteins and all, right? So to which protein these autoantibodies are produced? So they are produced against glycoprotein 2b3a or glycoprotein 1b9 complex. So these two are the main glycoproteins where these antibodies are produced, and they are mainly synthesized within spleen. So whenever these platelets they enter the spleen, they cause the destruction of these sensitized platelets, that too within the spleen itself. So as these are destroyed now, destruction has occurred, so they has to be removed from the circulation and all, right? So it will activate the phagocytes, so resulting in phagocytosis. So phagocytosis will occur by macrophages, resulting in again immunological destruction of platelets. So one is acute, wherein viral antibodies will cross react, and the other is an autoimmune disease, and chronic form will occur in adults. So now let's see clinical features. Now that we know thrombocytopenia, decreased platelets are there. So the main important feature of thrombocytopenia is purpura formation. So there will be spontaneous appearance of purpuric lesions on skin as well as oral mucous membrane, as you can see in the pictures. So this purpura, it can vary from tiny pinpoint petechiae to large ecchymosis, or to even massive hematomas also. In these three forms, this purpura can vary: petechiae, ecchymosis or hematomas. And if you see oral cavity, there will be severe gingival hemorrhages also, and bruising tendency also will be very fast. And there can be epistaxis, that is bleeding from the nose can be there, hematuria can be there, bleeding in gastrointestinal tract, melena or hematemesis, that is blood vomitings can occur. As you see in chronic ITP, the destruction occurs in the spleen, right? So there can be splenomegaly as well as hepatomegaly that can be observed in chronic ITP. So these are the various clinical features. Now let's discuss laboratory findings like any other blood disorder. So here thrombocytopenia, decreased platelet count. That too in ITP, the decrease in platelets will be much more less. It will be less than that of 50,000. Okay, as platelets are decreased, obviously bleeding time will be prolonged here. That too, it will be prolonged to more than 1 hour, and the clotting time is normal as there is no defect in the clotting factors. And if it is autoimmune, that is chronic ITP, then we can even see, if we do serological tests, we can even see antiplatelet IgG antibodies within the serum. Okay, and upon platelet survival tests, okay, wherein the platelet lifespan here will be decreased. The normal lifespan of platelets is around 7 to 10 days. So here the lifespan of platelets will decrease lesser than that. Okay, that can be dealt by platelet survival studies. So this is about thrombocytopenia. Idiopathic thrombocytopenic purpura. The next topic is thrombotic thrombocytopenic purpura. So this is one of the thrombotic microangiopathies, and it is very much different from that of idiopathic thrombocytopenic purpura in its pathogenesis. So thrombotic microangiopathy is nothing but thickening of the blood vessel. So how does it happen is, like, there are two main causes, TTP, the one which we are going to discuss, and the other reason is hemolytic uremic syndrome. So what happens in TTP, that is thrombotic thrombocytopenic purpura? So what is the pathogenesis of TTP? It is formation of the microthrombi. So this microthrombi are formed in various blood vessels within the body. That is the main reason behind TTP. So what happens when microthrombi are formed is that whatever platelets are present within the body, they will be all used up in the formation of the microthrombi, that the content of platelets will be very less for the clotting mechanism. So how does this microthrombi form in TTP? So if you see in this picture, this is the thing, that this is the blood vessel. So that is von Willebrand factor. So normally this von Willebrand factor, it is produced by endothelial cells. What does this von Willebrand factor does is, like, whenever it is produced, it helps in platelet aggregation and helps in thrombi formation. But as there is no injury, we don't need von Willebrand factor. So what happens normally is that there is another protein called as ADAMTS13. This is one enzyme, metalloproteinase enzyme, which helps in destruction of von Willebrand factors. That means it breaks down von Willebrand factor into pieces like this. So as there is no injury, we don't need von Willebrand factor, so that platelets will move around freely in the circulation. So this is normally. Whereas in case of this TTP, what happens is there will be deficiency of this enzyme ADAMTS13. This metalloproteinase will be deficient. So without any injury itself, our von Willebrand factor is produced, right, normally. So if ADAMTS is there, it helps in destruction. But now that ADAMTS is not there, so no destruction of von Willebrand factor. So what it does is, it brings up all the platelets together and helps in aggregation. Whenever they are aggregated, there will be microthrombi formation. And this situation can become worse when there is an underlying endothelial cell injury, which will produce more and more von Willebrand factors. Okay, that results in using up of all the platelets which are present in the circulation in the form of microthrombi, and later on occluding the blood vessels also. So as all the platelets are used up, what will happen? Thrombocytopenia only will happen, right? So now that is the mechanism of TTP. So what we'll see in clinical features is that thrombocytopenia, hemolytic anemia, fever, neurological dysfunction, and renal failure. These are the very important clinical features that are seen in TTP. So what will be the laboratory findings? Thrombocytopenia, so decreased number of platelets within circulation, because everything is used up in the microthrombi formation. Whereas upon Coombs test, if we do Coombs test, we can see microangiopathic hemolytic anemia also. And the best way to check for TTP is doing a biopsy. The best way is doing a gingival biopsy again. So when we do biopsy under histopathology, what we can see is all the blood vessels, they show microthrombi formation. So if you see, this is the histopathology of TTP, wherein see this is one blood vessel wherein the entire blood vessel is filled up with a microthrombi. Like that, many blood vessels, that is this microthrombi, they can be seen in arterioles, or it can be seen in venules or capillaries, in any tissue or any organ for that matter. Okay, that is the main pathogenesis behind TTP, and that is what you can see under histopathology also. And what does this thrombi will contain? Thrombi will be composed of loose aggregates of platelets which are organized into amorphous plugs. So this is about thrombotic thrombocytopenic purpura. And next topic is a very important one, hemophilia A and B. They are also called as bleeder's disease, disease of Habsburgs, or disease of kings. So this hemophilia is basically the most commonest hereditary coagulation disorder. Hereditary. So here, why this hemophilia A, the factor which is defective, it is present on X chromosome. So here the main pattern of inheritance is X-linked recessive inheritance pattern. So that means like the males will be affected here, whereas females who are affected will be in the form of carriers. Okay, so males are affected and females will be carriers. And hemophilia, it is basically three types, hemophilia A, B and C, where hemophilia A is caused by deficiency or defect in factor 8, that is also called as anti-hemophilic globulin. Whereas hemophilia B, it is by a deficiency of plasma thromboplastin component, which is also a Christmas factor, which is also factor 9. And next is hemophilia C, which is plasma thromboplastin antecedent. This is kind of rare. This hemophilia A, which is caused by deficiency of factor 8, it is also called as classic hemophilia. Whereas hemophilia B is called as Christmas disease. Why? Because the factor here, that is factor 9, it is also called as Christmas factor. So what happens in hemophilia A is that usually the liver cells or hepatic parenchymal cells, they synthesize factor 8. So this factor 8 along with von Willebrand factor, what it does is like it helps in activation of factor 10 in intrinsic clotting pathway. So any defect or any deficiency of factor 8, it results in defect inactivation of factor 10, resulting in defective clotting mechanism. So what will be the clinical features? Now that clotting is defective, that hemophilia A doesn't, it has deficiency of factor 8. So what happens is that there will be persistent bleeding even after slightest trauma. So upon slight trauma also there will be continuous bleeding will be there, and sometimes the bleeding will be so much that the hemorrhage will be seen within subcutaneous tissues or internal organs and joints, which results in big hematomas, that is massive hematomas. And this severity of forming hematomas and all, it depends upon the amount of factor that is deficient. So degree of severity depends upon the amount of factor that is deficient. That is, some patients will show only rare and mild bleeding, whereas some will show frequent and severe bleeding. So that depends upon the amount of factor. Okay, so orally, that is in the oral cavity, the main important feature will be spontaneous hemorrhages, gingival hemorrhages, as you can see in the picture. So gingival hemorrhages will be very massive and also prolonged in nature. And other than gingiva, there are other sites within oral cavity also where hemorrhages can be seen. And one more important feature is pseudotumor formation. So what is the pseudotumor is that there will be subperiosteal bleeding. So this subperiosteal bleeding will create reactive new bone formation. Whenever there is reactive new bone formation, it looks as if like a tumor like expansion, which is called as pseudo tumor. So these are the various clinical features that are seen in hemophilia. So what are the laboratory findings? So here it is a defect in clotting factor. So now the clotting time will be prolonged here. And I told you factor 8 will activate factor 10 in intrinsic pathway. So this activated partial thromboplastin time, which is prolonged here, actually this APTT time, it evaluates the intrinsic pathway. So now that factor 8 helps in intrinsic pathway, right? So that is why APTT will be prolonged and clotting time will be prolonged. Whereas prothrombin time will be normal. Why? Because prothrombin time will evaluate extrinsic pathway. So extrinsic pathway is normal here, right? So prothrombin time is normal, bleeding time is normal. So now this inheritance pattern as well as clinical features of factor 9 deficiency, that is hemophilia B, will be very much similar to that of the classic hemophilia or hemophilia A. So more or less both will be similar. So the next important disease what we are going to discuss here is von Willebrand's disease. This is also called as pseudohemophilia or vascular hemophilia or vascular purpura. So here what happens is there will be defect in von Willebrand's factor, that is both qualitatively as well as quantitatively. That means there can be decrease in the number of the quantity of the number or quantity of the factor, or the quantity can be same but the function of the factor can be defective. So there can be qualitative or quantitative defect in the factor. And here the inheritance pattern is autosomal dominant, whereas hemophilia it is X-linked recessive. So how is it different from hemophilia is that here von Willebrand factor it is synthesized by endothelial cells and platelets. And mainly von Willebrand factor, like I told you before, it helps in adhesion of platelets to subendothelial collagen. So whenever there is any injury, this von Willebrand factor it helps in adhesion of platelets to subendothelial collagen resulting in clotting. So if there is a defect either qualitatively or quantitatively in von Willebrand factor, there will be a defect in clotting mechanism, that is adhesion of platelets will be difficult, deficient here. So here bleeding, it is a bleeding defect, not the clotting defect. Okay, so what are the clinical features what you can see here? As platelets are not aggregating because of the defect in von Willebrand factor, there will be excessive bleeding spontaneously following a minor trauma. And this even orally also, that is gingiva shows spontaneous gingival bleeding. And sometimes, like usually when can we discover this von Willebrand's disease is that after extraction usually the bleeding will stop within 15 minutes or half an hour, but here there will be prolonged bleeding which continues for several hours. Okay, this von Willebrand's disease it is of 3 types depending upon the quantitative and qualitative defect of von Willebrand's factor: type 1, type 2 and type 3. So here type 1 and type 3 are quantitative defects, that is there is reduced quantity of circulating von Willebrand factor, wherein type 1 is the most commonest one, whereas type 3 it is rare but it is a severe form. Whereas type 2 it is opposite of type 1 and type 3, that is here it is qualitative defect, that means the amount of von Willebrand factor is good but they are functionally defective, that means they will not activate the platelets in aggregation. Okay, so this is about clinical features. Now we'll see laboratory findings of von Willebrand's disease. As here it is a defect of platelets, right? That is it is not causing the platelets to aggregate. So bleeding time will be prolonged here, but clotting time will be normal only because there is no clotting factor deficiency. And normal platelet count is not decreased, only the aggregation of platelets only is not happening here, that's all. And definitely if it is type 1 and type 3 type, there will be reduced plasma von Willebrand factor concentration, and there will be increased capillary fragility test as well as positive tourniquet test. So these are the various laboratory findings of von Willebrand disease. So these are the various bleeding disorders, that is important bleeding disorders that we have discussed here. So what all we have discussed? Thrombocytopenia, which will be presenting in the form of purpura, and it is mainly of two types: immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, which has different pathogenesis altogether. And next we have seen hereditary coagulation disorders like hemophilia A and B, and then von Willebrand's disease, wherein one is because of clotting factor 8 and the other clotting factor 9, and the other one is because of quantitative and qualitative defect in von Willebrand's factor. And once you know the pathogenesis of the disease, you can write about the laboratory findings and the clinical features very much easily. So try to understand the pathogenesis behind the disease.